Discussing this matter of the human architecture of healthcare digitization and using Gurkey Hospital as a case study, right? Um, I apologize for the long topic anyway. It was a bit hard to put into words what I wanted to pass across and all, but this seemed to capture it. All right. And let me put a tiny story. I'll make reference to it anyway in the course of our brief talk here. Uh, in 2015, I joined Gurkey Hospital, um, and well, it was about that period that we're starting off with this EMR implementation project. And I can't remember who I got that advice from, whether it was one of the development team or my past bosses. But they were like, if you're involved in some project or the other, and then you encounter a point at which things get sort of complicated, just look for the three P's, right? Three P's. And those were the problem, try and find out whether the problem is coming from people, try and find out whether the problem is coming from the program you're deploying, and then whether it is based on the processes that the people are supposed to be using, right? And in the last 10 years, I've actually seen scenarios in which EMRs have been deployed in other hospitals. You get to interact with people from other healthcare facilities, and they all seem to have different experiences, you know, sometimes different experiences from ours here in Garki and so on. And if there was one thing I'll say was a common trend all through basically, is that people tend to look for a silver bullet, something that would make their implementations really, really awesome and impactful. Okay. But there isn't any one single thing. It's usually a combination of factors pulling together in the same direction, pulling together. So when we're talking about what makes, healthcare initiatives like this, digitizing your healthcare processes and all, right? You don't have just one single thing that actually, plays a part in there. You have several, but these three things tend to have a major impact. And like I mentioned, those were the processes, the people, and the application. But that's quite a large topic. So for today, I'll focus a great deal on the human aspect. I may touch on the other two that I've mentioned so far, but I'm going to focus mainly on the human aspect. So, what are the ingredients for a successful healthcare digitization initiative? Okay, and the question we're going to try to address in the course of this interaction is what will be our success criteria? And like I said, we're using Gurkey Hospital as an example. And why do I say I would rather focus on the human aspect or our stakeholders? Okay, and the stakeholder basically is somebody that is affected by a a solution that you're trying to bring in, and that same person can also affect the implementation of that particular solution that you have. So these people, your stakeholders, are actually very, very important. All right. Yes, you may definitely have, these are the three P's I was referring to. Your program needs to be able to meet the needs of your stakeholder. All right. It should be able to cater to their every single, it should enable them to achieve their objectives. All right. And basically, these people have tasks in their organizations that they're supposed to carry out. So your application should contain the components of your solution, should be able to meet the needs of these different individuals that you have that are working in that particular organization. And our hospital is an example of such a place. You have a wide range of professionals working in a single place, and they're expected to, deliver value. Your application must be able to meet those particular needs, right? But our experience in Turkey has also been that a large part of it, challenges that were encountered in the beginning, were because the processes themselves were not so were not well articulated. So part of the things that we had to do was to enforce, documentation of the processes for the different units that we have. Okay, so this one is just pretty much like an overview. And in the course of this conversation, I would make reference to a few things from the business analysis body of knowledge, right? That's the BA book. And the reason for that is it's goes a long way in capturing what anyone tries to do in any initiative, whether whatever project that you have and so on. What do I mean by that? There's the core concept model that's introduced in the BA book. That's the business analysis body of knowledge guide, where they talk about six key things that are very important for any successful implementation. You need to recognize these things and work with them, understand how they are. The first part said is the change, which, well, is the change that you're trying to implement. Say, for example, you're trying to move from, like a hospital scenario we're talking about, you're moving from a paper-based way of handling things where patient records are in files, payments are made, and then on paper, recorded on paper, and things of that nature. We're trying to move away from that process, right, to electronic means. So that in itself, that transformation is the change. And it's usually in response to a need. And they express a need as either a problem to be addressed or an opportunity to be seized. Okay. And your solution is the specific way of satisfying that particular need, right? And in the midst of all that, you need to now work with people, your stakeholders. They may be groups or individuals that have a relationship with the need, the change, or the solution that you're trying to bring in. But you're not doing all of these things. You're not trying to digitize your processes just for the fun of it. You need to derive certain value, which was defined as worth or importance or usefulness of something to a stakeholder within a context. And the context, they said, is the circumstances that influence the change and also influence your understanding of that change. Why do I have to bring this whole thing in? Remember, I talked about the three P's. That's people, programs, and processes. So from the BA book as well, you find out that your people I'm referring to are your stakeholders. That's the human architecture we're talking about. We're talking about the interactions between these stakeholders. That you have the formal interactions and then you have the informal ones. The formal ones are more of like the things that you find on the organogram of your organization, and the informal ones are like the norms and behaviors or so of that particular organization, and also communication channels that may exist in there. So the P there refers to the first P, people. I'm talking about the stakeholders. And then the program in this scenario is the solution. All right, is a solution which can be like a combination. It may have several different components working together to actually try to generate the value. And the processes we're referring to when I said the third P is the context, is, well, pretty much the context that we're talking about in the BA book. But that's just to give a sort of like a background. Now, for those that are not familiar with Garki Hospital, okay, Garki Hospital is like was established in 1986 under the FCTA and was closed in 2001, but reopened in 6 years later, following a concession agreement between the FCTA and NISA Premier Hospital. And Garki stands as the first successful public-private partnership hospital in the country with a mission of providing world-class affordable care to everyone. From an infrastructure perspective, you say Turkey has 130 beds, runs several clinics 24 hours, right? 24-hour clinics. That's in our general outpatient department, and that's supposed to be POPD, pediatric outpatient department. Those clinics run 24 hours. And we also have several other specialist clinics, the antenatal care, dialysis. We have theater rooms for operating and all. And we also have lab services, radiology, pharmacy. There are several others that I do not include here for brevity anyway. We have physiotherapy and dietitian clinics, so many other things. And those are like, the clinical aspects of it. Then we also have the administrative aspect where you have your finance, procurement, managed care, IT, right? I've been in IT all along. So we categorize all those ones as being under the administrative aspect. So that's just like a background for the hospital. But when things kicked off with this concession in 2007, there were, of course, a lot of challenges based on the processes that they were using that were, that were not electronic. Everything was pretty much paper based, and the only thing that was electronic at the point was the accounting part, where they tried to make use of certain accounting ERP platforms like that. But everything else was still, manual. And you could find problems, you could find issues and inefficiencies from these paper-based processes at just about every single turn. Whether it is you're coming in for the first time and then you're being registered, your documents stored in a file and then kept by the medical records department. When you come back later on, especially if you have of course, a large hospital like this had a very, very large room for patient files. And it was a common thing for patients' records to get lost or misplaced, and then new ones will now have to be opened for them. And maybe those ones could get lost as well, and maybe some older ones could get found at some point, and everything just gets all mumbled up one way or the other. Reporting was also a problem because I know for medical records, they were supposed to generate certain reports on a monthly basis based on, say, antenatal visits, patient care, and different things. It's actually cumbersome and difficult to actually carry out reporting when everything is going to be based on what you're counting manually. Not to, and also to mention the exposure to risks, financial risks or clinical risks when certain key documentation is lost and you have a legal case in that scenario and your documentation can be found or can be relied upon. And even if you have, there are also cases of fraud in which people could take advantage of the manual processes and then be fraudulent. I think there were scenarios before the EMR came in where certain members of staff were caught, you know, either making falsifying receipts and handing those ones out to patients and pretending to be cashiers and things like that. So it was quite messy. And the solution at that point was to implement a hospital management system, right? The one that was eventually selected was the MediPlus EMR. But they also needed to do something. We also needed to do something for the other aspects. When we're talking about financial aspects, when we're talking about procurement and things like that, there was no point in having just one facet of the hospital running electronically. You needed to have it running across board so that the benefits could be realized in a in a more holistic form. And also the solution that was employed or was selected was the MediPlus EMR, and the developers that came with that's the Internet Experts team. They actually came and also brought along the Odo ERP. They implemented the Odo ERP and PACS for PACS integration for our radiology or imaging and things like that. PAC standing for Picture Archiving and Communication System, so that if a patient goes to radiology, doesn't have to now take a CD over from there to from they will provide a CD for him or with the images there, and they will now take it to the doctor to now view on their own system. With the PAC system, what you had was a case in which the images could be viewed even by the doctors straight from the consulting rooms. And the same thing, we'll get into a bit more discussion in that regard when it comes to the different features anyway of the EMR. But it wasn't just enough to implement an EMR solution. It was not enough to just deploy an ERP as well. There needed to be a means of the hospital network infrastructure also had to be upgraded. There had to be we had to get fresh hardware for the computers because a lot of not all the I think when we started off we had pretty much just like 65 computers in the whole hospital, but by the time we started off, right now we have close to 300 computers, and also it was a gradual progression. It's not something you could just do all at once. We just had to plan, the upscaling of our infrastructure in a gradual way. All right. So, for those who are not too familiar with EMR platforms, or well, health management systems like that. This is like an overview. What it does is that you have an application that's like a central point for addressing or for handling all the processes that you have in a hospital like that. So hospital like Gerke has so many different disciplines and all, and so many different departments. So just we deployed the EMR, the MediPlus EMR, right? And it had several modules like that. So they took care of almost every single thing, whether it had to do with appointment scheduling for patients, uh, registering the patients to start with, then appointments, consultant management, billing and invoicing, outpatient, inpatient, all of these things were handled by and expected to be handled by a fully functional EMR. And as we rolled the application out, it was easy to actually now see the improvements close up because you just knew that at the point of patient registration in the past, the patient had to come in with their own with their what they call these cards. It's been so long ago, I can't even remember the name of the thing. But more of like their patient cards with their patient numbers on it, so that the patient could be, they we could use that card and the number on the card to track the patient's file. These days, the patient will just come in and provide their name. If they can remember the EMR number, provide the EMR number. If they can't, they can just provide their phone number, and their records will be pulled up to the system immediately to and scheduled to see a doctor or anything they want to do. And the whole thing about moving files here and there, the time lost by trying to find documents, that whole time was gained back because every single thing you didn't have to put a file in a doctor's room any longer and things like that. So it made things a lot faster. Billing and invoicing was a lot more transparent because almost every process, every single activity on the EMR is time stamped. So if there's a problem and you have to perform some sort of an audit, whether it's a financial audit or even a medical audit, you can actually go over the steps of every single thing that was there. So as we went on with the implementation progress, you would think that everyone would be, up for it and eager to jump into it and be a part of it. But there were a lot of people that needed to be convinced or forced, let me say, because when you are bringing electronic systems into an environment where people were not accustomed to it, the last thing some people will want will be for anyone to know that they are not computer literate or they are not so computer savvy. So for those in those kind of scenarios, the options that they had were to ramp up their IT skills or to just find a means of you know of find some means of just being obstacles to the whole thing and all. But there are different approaches for addressing these things because while you're engaging in a project like this, you can't demonize anyone because at some point you would want these people to actually see your perspective and so on. So we had to interact with a lot of people, and in some cases, fortunately anyway, the hospital management was fully behind this, and yeah, they made sure that people that were not in line were brought in line and kept in line. But then in the long run, people, it became, if you ask anybody right now that if they wanted to go back to how things were 10 years ago, they would definitely say no. So, okay. So let me just give a bit of an overview of how we went about the implementation. We could not just start off with every single thing. We had to make a phase. It had to be in phases. There were three different solutions at the beginning, right? The EMR, the ERP, and the PACS, and these had to come in like one after the other. I'm going to, the next slide will show us the milestones and timelines and every single thing and all. But just note that when it was time, when we actually did start the EMR implementation in October 2015, we didn't have to use the entire hospital. We just started with a controllable space. And that controllable space for us was the specialist clinic, where we had so many different specialties in there, the ENT, the family medicine, all of those ones, they were in a confined area. So it was easier to actually deploy things there and then monitor things there correct a few things, and then from there go and then expand to the rest of the hospital. So before we could even do the inpatient aspect, we knew that there was no point in which patients will be seen on the system, and then they would get to pharmacy or the lab or radiology and find out that they will have to revert back to paper. So we had to do things in such a way that specialist clinic, pharmacy, lab, radiology, all these ones were brought online very, very quickly in the initial phase so that patients could be really properly attended to in there. And once that was achieved, it was now easier to move from the specialist clinic to the GOPD clinic, the POPD clinic, the pediatric outpatient clinic, and then the wards and so on. So that's how it just spread gradually. All right. So these are this is like a rough idea of a timeline of how things went. We spent the first couple of months anyway before the implementation to look at different EMR options and then selected this one. And amazingly, I think there were two different sets of assessors, EMR assessors, that actually ended up with the same. We actually ended up selecting the same option from those that were available. That was MediPlus, and there are certain preparations that were required. I mentioned that in our own experience here, we realized that a lot of our processes needed to be documented, right, to make the work and a lot easier. And also, those were some of the preparatory activities that were going on. We were holding meetings on a weekly basis. I think those meetings were uh, daily briefly, but then they were now a weekly occurrence every Friday, so that by the time the implementation took off in full force, where we had those sort of like town hall meetings where representatives from every single department came and then aired their opinions and gave the developers useful feedback that was now taken to make the application even better. So those things happened in the third quarter of 2015. And by October 2015, the same year, we went live. And that was like, I think 19th or 21st, thereabouts. We went live with that. The PAX implementation and Odo ERP followed not too long after that. One of the couple of things that we had to also do was to migrate almost all our computers from running Windows to Linux platforms. And the reason was the rationale was very, very simple. We didn't want people to be worried about viruses and then having to actually also wanted to save the hospital money for installing antiviruses on all the systems. The number of systems was actually doubling, and also it was easier to move to Linux operating systems. It wasn't that easy for every single person, but of course, the IT team had to learn that one first, get familiar with the interface, and then walk people through it. Of course, people were kicking and screaming and resisting, but over time, they realized that these applications, because the EMR was web based, it didn't really matter what operating system you were running it on, right? And like I said, it was one of our many cost saving measures and all, because we didn't have to bother with getting genuine Microsoft Office operating system, Microsoft operating systems, Microsoft Office suites, and so on. So nothing wrong with that one anyway, but that was just where we were and what could be done at that point in time. So what was going on between 2015 and 2017 was the implementation in the clinical aspect. Remember, we mentioned the Odo ERP. That one also had to, when we had gotten some degree of stability with the EMR implementation, that was when now took on the Odo ERP deployment, and that went along the same lines. You have your stakeholders on ground, and then you discuss with them and have meetings and implement and things like that. So up till now, we're still using these platforms. We're still using the EMR. We're still using the PACS. We're still using the Odo platform. But part of the things we realized was that for us to actually take advantage and meet the needs of our stakeholders that we're talking about, there needed to be a more efficient way of communicating. And this was not part of the project, but it needed to be in there, and that was the reason for us implementing and or deploying an internal email server. Because up until that moment, if anyone wanted to have a meeting and invite, the attendees for that meeting, you had to print it out, make photocopies. So if you had 30 participants, you had to have 30 sheets of paper, you know, wasted like that and all. But with the internal email application, it just allowed us to, have electronic correspondence rather than, the paper and all, which was a lot faster. It wasn't taken on so easily, but of course, it was one of those things that the the sponsors of the project, that's the medical director at the time, clinical director, they enforced and saw through. All right. And as a result of their own commitment to it, the hospital now realized the value from that. So those were the things that contributed to us achieving, the 80 to 90% reduction in paper consumption and things like that. So over time, while all this was also going on, it was important for us to actually build capacity of the IT team. And I'll go into a lot more detail to how we went about that later on. And the result of the building the IT capacity was that we were able to, as stated in the milestones over there, deploy a server for replicating the database that we had here, so that in the event of any disaster whatsoever, we had something. The hospital wasn't going to start off from scratch. We weren't going to lose all the patient data and all. And it was not, it didn't mean that we didn't have backups. We had backups, but the problem basically was that if your last backup was taken, let's say 6 hours ago, and you had to pretty much stop your SQL server to take another backup, right? What if something went wrong, you know, 5 hours after your last backup? You are going to lose all those particular transactions that transpired during that interval. So we needed a real time solution. And based on the capacity that we built in there, we're able to deploy that one. The replication server was kept in NISA server room and all, and we had to configure everything in there to just ensure that the EMR could have that continuity, in the event of any disaster and all. So having done the replication, it was the next thing basically was like, hey, you know what, we could actually, this wasn't rocket science. We could build some additional applications that could, generate greater value for the hospital and reduce the pain points of the patients. So that's where the appointment scheduling portal and the IT help desk came in as well. So but this whole talk, before I get to, drawn far away, the reason we're here or is to focus on the role of the humans, the role of your stakeholders basically in there. And this cannot be overemphasized, right? Because alluding to the business analysis perspective, they said that they categorized the stakeholders into, like 10 different groups. You had your regulators, domain subject matter experts, project sponsors, project manager, business analysts, support, implementation subject matter experts, end users, testers, customers, and partners. All right. And in hindsight, looking back then, we didn't really know much. We didn't even know that business analysis was a thing, right? But we had personnel, we had people that were acting in each of these roles, and these people discharge their responsibilities therein. And say, for example, the medical director, clinical director, they were the sponsors for the project. They ensured that the necessary resources, the necessary manpower, every single thing that was required. In fact, the will therein, because when you're trying to bring in change, there will definitely be some people that will be resistant to it. In that kind of a scenario, you can't just go head on. At that point, that's where you need the backing of the management, the hospital management, you know. But what if your hospital management is backing you to do something that is not really going to be productive? That's not going to be productive or meet the needs of the users. That's where you need to have your domain subject matter experts, right? Your domain subject matter experts were like people that are knowledgeable in that field. So whether it is dentistry, family medicine, the theater, all these people, all these, we had stakeholders, we had champions from each of these departments, and they contributed. And the result of the contributions is this fact that we can stand here 10 years down the line and find out that we built on a very, very good foundation as a result of the input of each of these people. Now, having an application that meets every single domain requirement wasn't just enough. You needed to actually also have an IT team that was ready to offer the necessary support, because you could find when people weren't so comfortable with or weren't so conversant with computers and all, the smallest challenges, would you find the hue and cry up and down the place and all. So the IT team was up and running. The IT team was actually running 24-hour shifts. Started that in 2015. I think towards the end of 2015, we started running 24-hour shifts, and we're doing that up till now. Just to ensure that if there was any single problem at any point in the hospital, there was always somebody on ground, so that nobody will have any excuse to say that, okay, we don't want to use this any longer, we want to go back to paper and all. We had to be on ground to ensure that everything was there. And we're talking about, well, very later on, we'll see what, the hardware and other things that came in and all. Then the outsourced development team, that's internet experts at that time. Yeah, they were our implementation subject matter experts and all. And pretty much every single end user that we had in the hospital was like a bona fide tester. And thanks to the email platform that we had implemented in the course, or we implemented in the course of this thing, it allowed end users to be able to communicate, document, and communicate their challenges, right? And then and forward those things to the IT team. The IT team will then go through those particular challenges, triage them, find out which ones had to do with had to do with the programmers themselves, and pass those ones across. But anything else that had to do with the internal departments reviewing their own processes, or whether anything that had to do with the users themselves being properly trained, were taken care of by the IT team, right? So it wasn't the case in which every single complaint from the end user went straight to the developers. The IT team actually had to stand in as middlemen and interface with the two sides, with the business of the hospital and also with the developers. And that one played a great deal because it was from the experience that was gained interacting and interfacing with every single person that allowed the IT team to be able to handle support issues when I think there was a period, whether it was 2018 or 2019, where the developers we started off with, the company was acquired by another company. So during that interval, there was a period where we could not obtain support, and at that point, it was the IT team that was handling the support issues, and we still handle a lot of support issues even up till now when it comes to the EMR and so on. So the point I'm trying to buttress over here is that you can have an excellent system, you can have an excellent application, you can have excellent infrastructure and all, but it's all as a result of what went into it, and what's gone into it comes from your from the human interactions, from your stakeholders willingly giving information to make the system better, make the application better by pointing out challenges and pointing out better ways to actually get things done. The implementation guys will now take the feedback and then develop, they now made the necessary changes and so on. Let me not also fail to mention the patient feedback was also useful. Insurance organizations and our corporate clients too, those ones were also stakeholders, and their feedback was taken on board at different points as well. Okay. I mentioned earlier on the importance of process and policy documentation, and this had to be done across board, right? It was part of the three P's that we talked about. And experience basically has been that if your hospital, your healthcare facility does not have clearly defined and clearly documented processes, you don't have flow charts, you don't have even at the minimum have a flow chart of your activities for every single business unit. That makes it easier to find out what's going wrong and when, and that also helps anyone in the event that they want to upgrade from one application, from one EMR application to a better one, or if upgrades are being carried out on the same one you're using. Documentation of your processes, your procedures, your policies, the reasoning behind your decision making is very, very important. And having those things documented, not having them in the brain of the oldest staff or the most hardworking staff in your unit, having those things documented actually makes a bigger difference. All right, because that's sort of thing that you can hand over to your developers. And yeah, like I mentioned, it makes life a lot easier going forward. Uh, right. So just to mention the other aspects, I talked about the people, I talked about programs. The IT infrastructure had to be upgraded all along, right? Because we started off with less than 100 computers, 69, 65 thereabouts, and when you double or triple the number of systems on the same sort of network backbone that you can have bottlenecks here and there. So these issues have to be identified and taken care of. In some scenarios, like in our case over here, we communicate with our insured care providers who have portals online. So that meant that a number of systems had to have access to the internet, even if not all of them, but they had to have access to the internet that could not be abused, right? And you also needed to have scenarios in which doctors didn't or consultants that were leading teams could still access patient records remotely, whether they were working from home or any place else. So all of these things were part of networking that we had to take care of and address. The servers, we upgraded servers each time we noticed a performance bottleneck. And server performance wasn't so hard to figure out. If it was a network problem, you would not be able to access any single service on your, any single resource in the hospital, whether it's the email platform, the Odo platform, nothing would work. But if the problem is the server, you find out that, okay, other platforms are working, but the EMR wasn't working. And now had to look into that one and find out that, okay, one particular component of the server or the other, whether it was the processor, the storage, or the RAM, had to be upgraded. So all of these things were taken into, you have to take these things into consideration and all. I mentioned that we had a preference to the Linux operating system because it wasn't so vulnerable to the viruses that attacked and plague your Windows computers, right? And yeah, you always had to have a disaster recovery plan. And for ours was the offsite data replication for the EMR. The other things were backed up within the server, within the server room and all. But the most critical thing to us was the patient data that we were custodians of. The last thing we wanted was to have some sort of disaster, let's say fire engulfing the server room, and I realized that we lost 10 years of patient data. No, we had to have that backed up. So you just have to prioritize, know the things that you can do without, and know the things that you can't do without. And for us, yeah, that was one of the key aspects. Okay, so I mentioned that while talking about the role of the impact of the human architecture in a successful EMR implementation, I cannot emphasize enough the importance of the IT team. And it seems to me that in hospitals generally, well, maybe things are changing now, but then hospitals generally tend to, yeah, they focus naturally on the doctors because the patients came to see the doctors. No two ways about that one, right? But a lot of effort needs to be put into your IT team and building the capacity of the members of your IT team, whether you're a small healthcare facility or one that's like, or a very, very large one spread across the country and things like that. Because if you want to store your information on IT infrastructure, you want to store it in the cloud or you want to store it on premise in your servers, hard drives, and things like that, you would need to have a competent IT person or the other one, IT team, to handle things for you so that you would be spared the trouble of maybe small issues that's like virus infections and things like that. And beyond that, the responsibility of the IT team is actually take decisions, and the heads of the IT team is take decisions that will secure the future of that will future proof your initiative such that your deployments will stand the test of time. Okay. And Gerke Hospital couldn't, anyone asking Gerke will attest to the fact that they couldn't have done this if the IT team hadn't been there and hadn't grown in the way they hadn't evolved. First of all we were doing was offering support. You know, okay, a mouse needs replacement here, a UPS needs replacement here, a network port needs to be replaced, a network cable needs to be crimped, things like that. Someone didn't know how to use Microsoft Office. We showed them how to do that. But the IT team had to evolve beyond that and take on new roles and new challenges. And that's why right now we're talking about developing our own proprietary HMIS application. And the reason is very, very simple. We I talked about the time that the application that we're using, the EMR right now, was taken over by a fresh team. Now, imagine a scenario in which it was a one-man business that was running the thing, and the single owner and the single spearhead of the development team passed on, and there wasn't anybody else that could take up the slack. That's where your IT team comes in. Okay. That's where they're supposed to position themselves for such scenarios. The same way that they act as the buffer between an end user who's dissatisfied with your product and a developer who doesn't understand why the end user is dissatisfied. The same way that the IT person in the middle stands like a buffer, absorbing the heat from here, absorbing the heat from this place, but but not allowing that the heat or the pain from one end to be transmitted to the person on the other end. They absorb a lot of this. That's the same way that the IT team is supposed to actually absorb those risks that could come with your developers. Okay, that will come with any external development team that you have. You're more stable. You stand a chance of having a more stable existence for your digitalization exercise if you have an IT team that is growing with the demands of the organization. Okay, so wow. Okay, I don't have so many slides after this one. The rest I can just quickly run through. I've already heard about the reduction in the paper-based workflows, reduction in that, and then reduction in patient wait times that we've experienced, right? And the disaster recovery efforts and the recognition we've gotten and all. So those were the things that resulted from the approach, and these are some of the lessons that we learned in the whole exercise. I've mentioned already that process documentation, you can't do without that in any EMR implementation. As a matter of fact, if your end users are not willing to sit down and generate flowcharts for or process flows for their activities, then they are outrightly attempting to sabotage your exercise, because that is what's going to form the building blocks. It's from the process that you get to know whether a certain application will be a good fit for your organization. That's if for healthcare organizations that are not yet using digital platforms, the first thing you can do is at least ensure that every single thing you do, how you do it, and why you do it is documented. That will assist whatever team comes in. That will even assist your own team in assessing the different available options and deciding which one meets your needs, because your process documentation will serve as a checklist that you can tick off and say, okay, solution A does one, two, three items, one, two, three, and four very well, but it looks like it may do four and five to some extent. Solution B is better at doing one, two, three, four, and five. Solution C can't do any of these ones, and so on. So you'll be able to make objective decisions. And I can't emphasize this enough. If you make proof that you made the right decision, is that your decision stands the test of time. So that's why um, the fact that Gerke Hospital has not used, I think that was in the last slide, right? The fact that we've had zero system migrations since 2015 is proof that decisions that were made back then, right, stood the test of time. Okay. And of course, we had to take several. Didn't mean that we didn't make mistakes, right? But the overall trend, right, of decision making and the approach that was used by the people involved, right, to those decisions to the test of time. As a side note or a small joke, somebody once said that is he loves the institution of marriage, and proof that he believes in he loves the institution of marriage was that, and he does it very well, is that he's been married like 5 times. Okay, so that's, well, some people will disagree with me anyway, but then that doesn't show that you are stable and so on. So the same thing, in my opinion, goes for goes for implementations. Basically, if you have to change after a couple of years, or you're forced to change after a couple of years, it means something went wrong down the line. And sometimes do an autopsy of the last one, and then find out the lessons that you can learn from that one. All right, and use those lessons in in your decisions for the next one. Just the main thing is to avoid repeating the lessons and the mistakes of the past and all. So if there was any lessons that we learned, yeah, process documentation, okay, and having KPIs and audits, factoring KPIs and audits in the design phase of your application is very important. And what I mean basically is that for our own, for our EMR, for example, when we're handling patients, insured patients care, some patients come for secondary services. That's services that the hospitals cannot give to you free of charge, but it has to be paid for by your insurer. So in such things, the insurers have to communicate authorization codes to the hospital, and that one can happen within a particular, it can take minutes. The benchmark is 45 minutes, and then it can, for some, it takes longer than that, and so on. With an EMR like this in place, I told you that everything is time stamped. So when a request is sent out and when a response is received, both incidents are time stamped, and then you can now generate or collect data from that and get to know which HMOs respond in a prompt fashion, which ones do not. So that's one single example where certain performance indicators can be built in. If there was anything that would wish we could do all over again anyway, which we're hoping to implement in what we're working on, is to build in KPIs and more stringent audits into our solutions and all. And yeah, I would have a preference for applications that are made up of small components that are working together, probably through APIs, than having one massive application, a monolithic application, that if one thing goes wrong somewhere, and you have to now wade through a lot of spaghetti code to get to the other side. And then if you make a correction somewhere, you have to be careful to ensure that you do not mess something up at another end and things like that. So those are some of the lessons that we've learned so far. And well, what next for the future? I've already talked about our plan on the in-house solution development, and that's working quite well. We're looking to, when we're done with that application, now work with implementing API integrations with our various HMOs, so that when it comes to processing claims and things like that, these things will be better automated. And thinking of automation, hoping to look into, taking advantage of AI, uh, natural language processing and other things for a lot of the activities that we're going on in here, especially the repetitive tasks and all. And with the Nigerian Data Protection Act in place, yeah, there's a lot of work to be done. Okay, these are some of the considerations. I should have put this as well anyway. Might as well put this under the lessons learned, that when you want compliance with financial regulations, when you want compliance with healthcare regulations and things like that, you should try and find a means of building them early into your application if you're a software developer. And if you're a healthcare organization trying to transition to another EMR, or trying to uh, uh, or you're trying to get one to use for the very, very first time, try and find out a couple of these things. There are some checklists that you can have. I think the NDPA have a series of checklists that you can use, go over, and use to assess the options that you have. All right. So at this point, I would, well, the conclusion basically, I believe, is that a successful digital transformation in a healthcare environment, it's not just about the technology. It's not just about having a wonderful application that has everything that you need. It's built on human collaboration. It's built on adapting to changes. It's built on having a vision of what it's going to be like in the very, very end. And yeah, if there's anything I would want to leave as a personal note is that if it could happen and if it's happened over the past couple of years, yes, it took years in Gurki, it can happen even a lot faster in your own facility and everywhere because there's no point in repeating mistakes of others. Going ahead and then making your own mistakes. You can learn from the mistakes of others, and then Gurki Hospital has has taken some steps in that regard. And this point, okay, I don't really think I have too much to say after this one. I'll just have to say thank you so much for listening. I know it's been quite a lot, and I'll pause for any questions and any feedback from my moderators. So, thank you so much once again for having me.
Thank you so much, sir. Thank you so much, sir. Please, everyone, give Mr. Stephen a digital applause. Thank you so much, sir. That was a wonderful one. You basically gave us, the report of your work so far um, in the hospital, and not just the report, a blueprint on how we can transition from the traditional medical records to the electronic medical records. That was a very good one, sir, very detailed, and I'm sure a lot of the listeners, got um, a lot of knowledge from this. So we appreciate you, sir. And so it's time for question and answers. Sorry, questions. It's time for questions, comments, observations, and so that our speaker can attend to them. The first one, let me read from the chats from Mr. Ibrahim Yusa. How were you able to get the various stakeholders to buy into the long rollout process? This has been a decade-long journey after all. What were the quick wins helped sell the ideas? And I think the other one is which local, that is Nigerian solutions were considered or were none found functional enough for your use? So, sir, please, the question is to you, sir.
Okay, thank you for those questions and the feedback. Thank you so much. Okay, so yeah, stakeholder buy-in was very difficult. Um, but part of the things that we had to do, what made things a lot easier for us was that the instructions came from the top. Okay, so it wasn't a case in which we were fighting upwards. We always had the backing of the medical director. I think it was Dr. Essen at the time. Dr. Ono Adamu was the clinical director and then later became the MD. And the current MD is Dr. Itio, right? So every single step of the way, right, there was always you. The process always had a sound backing, from the management, from the hospital management, all right? And if there were any the quick wins that we could refer to that shifted the tide in our favor, right? It was pretty much the smiles and the impressed looks on the faces of the patients as they came in and went about things. A lot of them were accustomed to moving from the waiting area to the nursing station to have their vitals taken, and then they were waiting for the medical records staff to take their files to the doctors, and then maybe after the doctor has seen them, they'll be waiting for a printout of the results from the lab to now take it back to the doctor and so on. Only to now find out that everything was interconnected, every single thing. So the doctor will call your name out from the queue. You find out that the doctor would even have your previous history available. So when they're making decisions, it's sound. It's not based on what we call it. It's not just based on what's going on with you at that particular point in time. And another big thing was that it exposed a lot of fraud. It exposed financial fraud. it exposed insurance fraud because on the EMR, you'd have, especially if you're an insured patient, you needed to have your photograph taken. And if somebody else comes in and the picture, the person that's presenting has a is different from the person that's been photographed, I mean, the picture that's in there and stuff like that, it's easier to identify. So those were some of the easy things, and there were many at almost every single department. There were wins there. You go to the lab, you go to, in fact, the queue management application that we built in house. We actually did it because of the radiology unit, because over there was always some sort of a crowd and all. But the solution that we deployed in there that was different from the EMR. Just the solution in there would have a huge screen with the different imaging rooms, whether it's the X-ray room, the ultrasound room, the CT room, and all. And you had the names or EMR numbers of the patients listed in there. Well, most times the names anyway. You had the names, so people just came in and then sat down and saw that their names were on the queue and they could tell their position on the queue and they knew they were next and so on. So those were some of the things that people were seeing. And yeah, anyone, and you'll be surprised that there were still some people that argued against it, but it got to a point in which if anyone argued against those things, the progress we were making, they probably had something to hide or were afraid of being exposed in one way or the other. But the key thing actually was that the hospital management, the leadership, they were hands on, right? They knew the ins and outs of the application as well as anybody else in ICT, as well as anyone in the developers, in the development team, and so on. So when people were confused, they could come to they could come to the MD, they could come to the clinical director, and he could say, "No, you didn't try this, you didn't try this," and so on. And that actually went a long way because they were hands on therein. Then regarding the question regarding the solutions we looked at, I can't remember. There were two others. One of them I think was either e-health or e-pharmacy. The Udo thing, but we didn't really break down in too much detail. And part of the rationale or the reasoning behind us going with the Internet Experts team that time and the MediClus application we're using now was that we knew that um, we knew that we didn't really know so much, but we wanted a solution and we wanted a partner. We wanted a development team to partner with us for something that will go over a period of time. Not just, we didn't want somebody that would just come, deploy something, and then take off. And we'll have to now start searching for the person whenever there were problems. And we didn't want a scenario in which um, we didn't want a solution that was like that was self-contained in the sense that you couldn't add anything to it, you could not modify it, you could not customize it, and so on. And those were the things that we looked at. All right, we also wanted some degree of control over the database, in the sense that we wanted to be able to generate our own reports from the my directly from the MySQL database. Okay, we didn't want to all have to rely only on their reports and so on. So these decisions in terms of, okay, how scalable is the application, can you customize it to your needs, does it have room to accommodate your future needs? And the future needs were very, very important because in the beginning, and the funny thing about the future needs is that the change, earlier on I talked about the business analysis core concept model where they were talking about changes in response to needs. You can also have needs that will come up as a result of the change that you've undergone. All right. So as you embark on the journey of going electronic, you learn some things, and then you now discover that some other things can be improved upon. And that's just been it. It's been a process of continuous elaboration. And we wanted an application and partners in the sense of the development team that shared that vision with us and were ready to be with us for the long haul. And we're ready to, I must attest that they actually they were eager and willing to hear every single complaint that came their way, because they knew that that was the only way they could make their application even better, and they were in it for the long haul. So yeah, that's my response in terms of the applications that we, the platforms, the EMR platforms that we examined, and the reason why we picked this particular one. I don't know. I hope that addresses the some of the questions there.
Uh, Mr. Ibrahim, does that address the question? Your question? I think that's fine, sir. Any other questions, please? Comments? Is there anyone with a question or comment? Okay, so let me just make some comments and maybe in the course ask some questions. Again, sir, I want to thank you so much for this elaborate, very detailed presentation. I'm telling you, I had a lot of questions at the beginning when you started, but I found out that you answered a lot at the tail end, just to show that, you had the robust, you had a robust plan, while working on this presentation. So I'll start with the core areas you mentioned in a system, which are the people, the program, and the processes. And you mentioned, the key stakeholders. You talked about the technology behind, the different technologies behind um, this transition to the ERM. And you also mentioned the processes. Um, for the people, what I'll just try to summarize all you said about like answering the question to how do you get people to tag along, how do you get their buying, how do you ensure the processes are well articulated. I think we can zero that to a proper project management structure. And I've seen that a lot even in your stakeholder strategy. I can see how, you broke down the different stakeholders into different roles, and I can see that project management structure there. So I would just say that anybody who wants to do this level of detailed work would have to have some project management approach. And I'm sure you will agree with that, sir. And then
Yes.
some of the other things I picked, I saw the PPP, the PPP arrangement that brought about this change, or
Yeah.
this particular solution. That shows that PPP works.
Yes.
When
Yes.
we come together, the public and the private, coming together, it works. And you also mentioned about what has changed from the traditional, especially when it comes to what encouraged, the developers and everyone when they saw you said when they saw the smiles on the patients' faces and all that. I'll
Yeah.
use myself as an example, as of course as a patient too. Even though I'm not with Gariki Hospital, but an hospital that also adopted what you're doing, is
Yeah.
that the usual thing is to take your hospital card, then
Hmm.
line up, then take it everywhere, then they will check the file. They can waste like maybe 1 hour of your time just checking the file, you
Yeah.
know. And,
Yeah.
and that used to be very, in short, that alone can discourage you from going to the hospital. That alone, knowing
Yeah.
that you have to go through all that stress. And
Mm.
like you said, now you just go to the counter now, or to the particular person that will attend to you, and just give them your phone number. The other thing is, I'm telling you, several times, or yeah, that we forgot the card at home, and that was it. Get your card, no more, no more hospital for the day till you go and get that card. But with the phone, so a lot has changed, a lot has improved, the process has improved, time saving, and he said it has also reduced fraud and all that. So I was able to pick that. Then, so I'll ask a question now. Just maybe
Okay.
just tell us briefly. You mentioned about the different solutions, the programs. You mentioned about ERM, which I believe is the electronic medical records. You mentioned ERP,
Yeah.
that's the enterprise resource
Resource.
planning
Yeah.
system. You mentioned about PACS. Yeah, I think that's
Yes.
But
Um,
yeah,
picture
the picture
picture
archiving
archiving and
and
communication
communication
system.
systems. So I
Yes.
just want you to talk about the differences because I know there's a thin line of
Okay.
similarities
Okay.
between amongst them, and
Yeah.
so I would like you to speak on that, and then getting feedback from stakeholders. You've answered that question.
Okay.
But I know it's a continuous, it's a continuous
Process.
thing. You have to just
Yes.
keep improving the system and all that.
Yeah.
So maybe you still talk a bit more on how to get this, in real time. How do you get this feedback in real time from your users or from
Okay.
the customers,
Okay.
and possibly the operators to the ones, the IT team and all
Okay.
that. Do you have a form? Do you have a feedback form you use and all
Okay.
that? And you also talked about Windows, the preference of taking Linux over Windows, even though we know
Yes.
Windows has 70% of the market share and
Yeah.
most people. And but it makes sense to reduce, like you said, to avoid virus. I
Yeah.
think that's one key thing about Zynox, avoid virus. And I think it doesn't take as much power to run them as Windows. And I
Mm.
remember the first time we met, when you came with your MD to the Raspberry
Yeah. Yeah.
event that Mr. Ibrahim also invited me to. And
Yes.
you talked about how it was necessary for you to change most of your systems to Raspberry Pi so that
Yes.
to reduce power consumption and all that.
Y-
And I believe they run on Linux. And
Yes. Yes.
yes, sir. So and you said it was 80 to 90%. You achieved 80% paperless.
Mhm.
Um, so that's to say that is it possible for us to have this is another question, sir, that maybe just
Okay.
technical. Is it
Mm.
possible to have 100%
Okay.
paperless system? Because
Yeah.
right now in NSC, that's
Yeah.
what we are trying to do something similar in NSC
Okay.
now. And I'm privileged to be part of that team. We're going to be looking into that. And they are saying 100% paperless. And if you've been trying this thing for a decade now and you are here to go 100% paperless, I just want you to give us an idea. Is it possible or is it a thing is it that we still need to have that paper, that we need to still have that paper system embedded in it? Because
Okay.
one of the things why we're trying to have that paperless is for the ISO certification, which also
Okay.
Mr. Ibrahim Issa is the one pushing that in the NSC. One of the requirements so let's just give us that idea since you've been in the system. Then okay, you said your in-house, one of the in-house solutions, because you said you had some in-house solutions
Yes.
embedded within the system, and
Yes.
which I noticed that you said it was the IT help desk. Maybe just give
Yes.
us a bit of hint on that.
Okay.
Then, when you said process and policy documentation, you see, I was so happy when I saw that because it's one of the things I've been telling my team members.
Mm-hmm.
I'm privileged to lead a team now in NSC, to come up with some solutions like that. And from the beginning, what I'm trying to do the most is documentation. And some
Okay.
people are seeing it as waste of time. They just want us to go straight to this is the solution, that one, that one. I said, see, this documentation is the foundation. In
Yeah.
short, many of us, when we face a challenge, is the documentation we'll go back to. If we
Yes.
have some gray areas, the documentation will go back to. Then for
Mm.
business continuity,
Mm-hmm. Yeah.
that at the end of the day, by the time we phase out, or they might change the team. Also,
Yeah.
what are those people going to rely on? They can't be calling us and telling us to tell them is the documentation they will go straight to. So I appreciated seeing that, and
Mm.
you mentioned it again at the end
Yeah. Yeah.
of the slides just to show how important that is.
Yes.
Uh, which other thing? And I like the fact you said zero system migration post implementation since 2015. I want to know if that means that you've not had any customer go out of the hospital, right?
No, no, no. But
Okay.
that since we
Maybe you were,
started with
sir. I don't want, I'm sorry, you said you take it together. Sorry, sir, for cutting
okay,
you.
yeah, no problem, no
Yes,
problem.
sir, don't waste time. Okay,
All
so
right.
I was trying to understand that, and And I'd also wanted to ask a question, but I saw it in your next steps. Now,
Okay.
what are you doing about the data protection of your customers because of the new law, the Nigeria Data Protection Act, compliance law,
Mm, mm,
that so I wanted to ask, but I was happy to see it at the end. I was happy to see the AI thing too, as part of the next steps you are
mm.
looking at, sir. So let me leave it at that, sir, and thank you, give you the floor to comment on this. Thank you so much, sir.
All right. Thank you so much. Thank you so much, engineer. Okay,
Mm.
so forgive me. I was actually supposed to insert a slide with key definitions at the very beginning, but along the line, I just threw that skipped my mind and all. So the EMR, right, stands for Electronic Medical Records. Now, around here, we generally use that to refer to any platform, any software platform that's used to store patients' medical records. Okay, that's used to store them for easy retrieval and use, across in the facility and all. But then you get to hear people also talk about certain differences, like I mentioned the HMIS. Okay, so the actual term I'll prefer is the Hospital Management Information System, and I see the EMR as just a section of it, the one that has to do with the actual patient's medical records, their biodata, and then the lab results and things like that. All of those things fit in there. Okay, and generally you get to hear some in the healthcare sphere saying that when you see the EMR is different from an EHR. An EHR is electronic health records, but they use that to refer to patient records that are stored at a central location and can be accessed from different facilities. So we tend to use the EMR to just refer to your patient records being stored in a single facility and accessible only within that particular facility. And then the EHR, electronic health records, is referring to the ones that are stored in a central location and it's now accessed by a pool of, can be accessed from a pool of facilities. Okay, so it means that if on an EMR, if my records are stored here in Garki, if I go to FMC Jabi, I would have to open a fresh card over there. They don't have access to my records here in Garki. But if it was an EHR, then that means Garki and Garki, NISA, FMC, they all pooled data. They'll get my own records that's stored centrally, that's accessible to all of these hospitals, right? But they will find my patient records there. So whatever hospital I go to is just the same file that is being updated. So that's the key difference between an EHR and an EMR. But then when we're talking about the general applications and so on, I personally just classify them as HMIS or HMS platforms and all. The ERP, which stands for enterprise resource planning. All right, so platforms like that. Those ones are for accounting. They are for because of course when your patient comes in and deposits money and makes payments for services that are rendered and things like that, you would need to be able to compute the calculate, okay, how much came in. So you need accounting, you need to have accounting features in there and all. And for consumables that are being used in the hospital and things that are being procured and used in the hospital like this, you need to have an ERP, because also on that ERP platform that you handle your procurement cycle. So on the ERP platform, and one of such platforms, you have Sage, you have Odoo. We use Odoo over here. So when it comes to procuring items, and then those items being received in the store, they are being kept in inventory. The inventory levels are being maintained on the Odoo platform. The payments for the suppliers and even the supplier details themselves are managed right, on the same Odoo platform. Okay. So so everything that has to do with money coming in and out and things like that, and even HR related modules, you get to find those things on the ERP, Enterprise Resource Planning application. Okay, so then I mentioned the PACS, which is the Picture Archiving and Communication System. So that's just purely for imaging. So you don't have your patients do not have to take CDs up and down and all. The packs that we deployed, Osirix is the name, Osirix. It runs on a MacBook, so well, that's what's being used as a server. So we had to expand the storage on that particular thing to be able to store patient images and so on. So with that one, the patient images that's been taken from radiology can be viewed by any consultant. Can be viewed within the consulting room. They don't need to take CDs up and down. And what that also means basically is that if the information is required in another facility, it can even be sent, it can be burnt to a CD if they wish. It can be sent via email if they wish, and so on. So having that thing on a web platform just means that communication to whoever needs it or whoever is permitted to have it, is very important. And thinking about the those who are permitted to have that, that's why you can't do any single thing without being aware of the regulations that are governing these things. And as at the time we started, I think the Nigerian Data Protection Act was being worked on and all. So yeah, we found out that the number of things that needed to be done, and people need to be aware of those things as well, especially when it comes to patient confidentiality and things like that, transmission of information, whether your information is encrypted at rest or encrypted in transmission and things like that. You have to be aware of those things, and you have to factor those things into the solutions that we are generating in this day and age. So I think that answers the first part of your questions on question number one. Uh, okay, before I jump into the 100% paperless, let me mention that for Windows and Linux, uh, Linux operating systems. There are so many, so it's difficult for one single virus to be used one virus that may address one Linux distro may not affect different ones. So that's why those ones are actually a lot more secure than your Windows, and they are cheaper, and they're not so difficult to use. They're actually so easy. And the funny thing is that once you're using a web platform like that, you can't tell the difference between a Windows system and a Linux system because they all run browsers and things of that nature. And yes, we've been using Raspberry Pis. We've actually added some more to our network. So, is it possible to have a 100% paperless system? Now that's interesting because if I was tasked with making anything 100% paperless, I'll first of all now I'll draft out the process flow and identify the areas where paper is taken from one point to the other. Let me give us an example. In our managed care unit, we actually have a series of like 3 or 4 units that work together to handle insured care in the hospital. And at some point, patient claims that are being sent to the insurance to pay for their patients that enjoyed service in our hospital. Now, those claims need to be vetted. Now, at the moment, they're not being vetted on our system. All right. So the claims tend to be, on average, printed, okay, vetted, and then taken back. So those are some of the areas that come to mind when I say that we've not achieved 100%. We've not achieved 100% paperless system here in Garki. Even in the store, I know that when a goods received note is received from a supplier who's bringing something in response that was to be paid for by the hospital, some of those items are stamped and then taken over to the finance department for payment processing. Even though a lot of these things can simply be done by uploading those same things to the purchase orders that are on Odoo. So It's just down to what functionality is available in the application that you're using. And if the functionality is not present, right? What steps can you now take? What steps can you now take to do that? So on my side now means that, say for the insured care vetting process that's going on, we need to have some sort of platform where different people can collaborate, see a document, and then append their comments under it. All right. So it may be similar to what you'll find in like a blog or the other, where people can post something online and then find the comments under it. Those are the sort of things that can actually go on in there. So that's an example of the bottom line of it is that before you can go truly paperless, you need to first of all identify the areas that paper is being used, that and then now find solutions around those specific areas, and then integrate those solutions with your already existing platforms. Another key one is even when payments are being made. If you have a payment gateway in your application, right, in your EMR, a patient can pay for certain services even before they show up in the hospital. A patient can book appointments before they show up. Things like that, So it's just all about down to documenting the process as it is right now, whether it's paper based or anything. Documenting that, right? Documenting that and then now analyzing it to find the better way to go about it. So anything can be paperless. The main thing is you just need to know where those things are and what the next best solution will be for it. And